Okay, should we start now? Okay, great. So we're going to get started with the next session, and yeah, they mic me up, so that might make it a little bit easier, right? Okay, good. So I want to welcome everybody. I'm Dan Lin. I'm the director of the IPCR, the Institute for Prostate Cancer Research, and work at the university. I have my clinical practice at the university, and then do a majority of my research here at the Fred Hutch. And so it's just really nice, as Pete said, really nice marriage between the University of Washington, the Fred Hutch, and the Seattle Cancer Care Alliance, really for our institute. And I always say every year that this is sort of the best morning of the best day of the year for the institute, for many reasons. Mostly just to see some old friends and also to meet some new people, and to give back to the community as well as hear what you want to hear from us. I mean, we love talking about our research and what we're interested in and what we're doing, but we also really love to hear from you and again have this relationship, and we really appreciate all that you do for us, for the Institute and for our community. So thank you so much. Today I was asked to kind of continue some of the discussions with regards to earlier prostate cancer as opposed to later stage prostate cancer. And one of my areas of research is active surveillance, but I decided to kind of take a step back. And I get this question a lot from friends of family members and family members saying, how do you really know how aggressive prostate cancer is? And so I have like 3 things to cover. I've spent about 5 minutes on each. First is to talk about how we really determine how aggressive cancer is. Like, how do we say, what do we look at to understand how aggressive a man's prostate cancer is? Also to talk about how we kind of categorize men. And then finally, and really talking about active surveillance, which is what I'm interested in, which is if you take the landmass of men diagnosed with prostate cancer every year, you know that, as you saw earlier from Dr. Nelson, over 150,000 men diagnosed every year with prostate cancer, over 150,000. At least a third or a half of them will have early cancer that really probably doesn't need to be treated. We call that active surveillance. I'm going to talk about that. And then lastly, really, I want to talk to you about these risk calculators that we're developing here and give you an idea of where our research is going on that level. So I showed this slide for those of you that have been here 8 years. You've seen this before. I showed it maybe 5 or 6 years ago. I haven't since. But this is not a new concept, that prostate cancer certainly is a variety of different sort of animals. The majority, as I said, of prostate cancer is this little turtle that's never really going to do anything at all, really, ever. Then there are the birds that unfortunately are flying away maybe before we can catch them, and then there's the intermediate rabbit, and we have to figure out which is which, and how do we do that? I'm going to run through that with you right now. So there are 4 major factors that affect when we think about what's kind of a stage, or what kind of aggressiveness of a man's prostate cancer. The first one is stage, so what we feel on digital exam. So that's just a rectal examination. The next is grade, and what the cancer looks like under a microscope. And then, of course, PSA, which we've heard a lot about already today. And then some issues by the biopsy. So I'm going to go through each of those individually. This is prostate cancer stage. So this is what we call clinical stage of prostate cancer. So this is how the prostate feels. If it's what we call T1, nice and smooth on the back here, you can't feel any bumps. Or can you feel a little bump? Or obviously, is it really involved? That's the digital exam. Now, obviously, many of you in this room have had this. It's not very accurate for many reasons. First of all, most prostate cancer diagnosed in the year 2018, almost all, over 80%, will have a normal exam. So just because there's a normal exam does not at all mean that there is no cancer. And then the last thing is it's very inaccurate. I mean, there are many men due to various reasons we can't even feel the prostate or can't feel it very well. So a bit inaccurate, but still we take that into account. The Gleason grading system, and I show this to some patients because I think it's important to know, this is what we're looking at under the microscope. We see basically just patterns. If it's very orderly and all the cells look pretty close to the same, that's low grade. And in fact, actually, we don't even grade these anymore. They're either what we call grade 3, grade 4, or grade 5, and you can see here, they just progressively look more chaotic. The more orderly the cell looks, the better it is. The more chaotic it looks, the worse it is. And we give it a grade, and that's how we come up with the aggressiveness of the prostate cancer. So we'll give it a grade. We give it a primary score and a secondary score, and we add it up, and we give it, so if there's mostly pattern 3, we give it a 3 plus 3. All this is kind of changed now, in many ways, we call it Gleason grade grouping. And instead of having a 6 through 10 score, it's a 1 through 5 score, and I'll show this on the next slide. We can just basically group these things together. Here it is. So whenever I see a man, at least one day a week, I'll see patients with newly diagnosed prostate cancer. They walk in the door. They just had a biopsy 2 or 3 months ago, and I see about 4 or 5 of these men per week. And the first thing I do on the sheet of paper, I say, well, I'm going to say, where are you in this whole scheme? Is it 6, 7, 8, 9, or 10? And 7 is divided into 2 different groups, and I usually draw the line right here, and I say less aggressive, more aggressive. We've changed out all this, and now we just call it 1 through 5. I mean, 1 through 5 makes much more sense than 6 with a weird little 7 division. So 1 through 5, and I usually draw the line right here, and I say on this side of the line it's less aggressive, and on this side of the line it's more aggressive. That's the first thing we look at is Gleason grade. That's the first thing I look at. The next thing is PSA, and again, rough groups, less than 10, 10 to 20, and over 20. And we just say basically lower risk cancers, higher risk cancers. The next thing I look at is those biopsies. And where are those biopsies positive or negative? And this is how we determine whether a man should have active surveillance or not. And this is the scheme. In general, we divide the prostate up into 6 areas. And we say if there's cancer found in one area, it's better than if there's cancer found in 2 or 3, or it's better than there's cancer found kind of sprinkled through the prostate. Not only that, those little pieces of tissue that we take out are very small. They're a little core of tissue, like a fine mechanical pencil-lead core of tissue. And we say, how much of that piece of tissue is involved? If there's cancer in a piece, is there just cancer in a little bit of that piece? Is there cancer in maybe half or a third, or is that whole piece full of cancer? And that really determines, and we say to ourselves, well, if it's not much cancer just in one little piece, it's low risk. Slow cancer. Probably not going to bother that person. And we can kind of put it all together into this. And I have a little bit busy slide, but I just put it right down the middle and I say, in general, if a man has low Gleason, low PSA, a little bit of cancer, a little bit in that piece, it's really probably should get surveillance. And I would say that the preferred option is surveillance in these men. And most people draw a line right here and say, if you could circle this, and if you've circled that grade and this number and this thing, you should have surveillance for sure. But if you're at all on this side of the line, most men go for treatment. Okay, and I know many of you in this room have had treatment because you've been on that side of the line. There are some in the country that draw their line like this, and they actually let this little guy in here that has a slightly higher grade. Somewhat debatable. I tend to look at the whole patient, and we can't really box things in like this. Which brings me to the next things that we're doing here and other places. So this is the national guidelines. And what the national guidelines, if you look it up online, and so-called NCCN guidelines, which stands for National Comprehensive Cancer Network. And we're one of these groups. We all get together about once a year, and we look at how can we group patients together. And they basically came up with this a long time ago. Just low, intermediate, and high risk, and they just put all those values, PSA, Gleason score. And then a few years ago, we said, that's kind of not very accurate because there are some men that might have a kind of a higher PSA up here but have low-grade disease. And so they said, well, let's divide them even more. And then they made a very low, and then they made a very high. And again, I think they're kind of blunt objects. They're kind of blunt instruments. And they said, okay, well, we're going to put a favorable intermediate. I'm not joking. This is kind of how it happened. And this is a completely, we were at our major conference last week in Chicago, and I was giving a talk for a big group, and I said, who made this up? I mean, I've never heard of this before. And it was kind of just made up in many ways. There were some data, but not enough. And they said, let's draw our lines right here. And again, I think that that's reasonable, although we can do better. And so what are we doing? What are we doing here to do that? So as I said, the pros to these types of things are that all these variables are very easy. We have all these things right here in right on the medical record. And there's a big history that has fallen there. But in most of those, there's no division between these two groups. The digital exam is very inaccurate. It doesn't account for putting things together. And I would say, again, these very low and favorable, they're just basically made up. There are others, and we've worked with others to add things in. So, and I can't go through the whole data, but this was a major effort where we got together with many groups and we said, hey, the volume of the prostate really means something. TRUS is ultrasound volume. So that's the volume of the prostate. How about we measure the actual millimeters, the actual tiny little millimeters? It actually added a lot of value. And now we have these things called nomograms that are quite complicated looking, and here's an example. And we can say, hey, let's put it all together and let's put in PSA and T-stage and biopsy score and how many positive cores and how much cancer. It's also a bit difficult because what it demands you to do is it says, okay, I have a man with a PSA of 7 and you get 60 points. And then it's this stage and you get 30 points. And then you just go right down the thing and you have to add up all your numbers. And once you get your number, then you have to go down here and then you have to find out where you are. Okay, so now we can do this on the computer, but also what don't you see on this? You don't see how old the patient is, really don't see if they're healthy or not, their choices, which Dr. Gore said about do they want to have, preserve their erectile function, what they're really valuing. And so, again, a bit of a blunt object, although I think it is progress. I'll skip this for sake of time. So the last point I want to talk about is active surveillance. So active surveillance is really a great interest of mine and here at the Fred Hutch and the University of Washington and the IPCR. And there's lots of facts about active surveillance. We know that active surveillance is the preferred management option in low-risk disease. So if we had a man with low Gleason, low PSA, and not much cancer, that is actually the preferred choice. They can have surgery and radiation, certainly, and I've done hundreds of surgeries on men who have that same type of cancer. But what's the governing body of the nation said, we should watch those men because most of those men don't die of prostate cancer. At the same time, after 10 years of, if you start 100 men on active surveillance, 50% of them will eventually have treatment for some reason. And about 50% of them will still be having active surveillance. And for any of you in the room, what that means is a biopsy every year or two. And whoever's going to undergo a biopsy, you know how that is. It's not very comfortable. And so you can imagine that a man's having biopsies every couple of years for 10 years and nothing's changed. So what is the goal? The goal here is to identify those men who are destined to progress and have treatment and get them off right away. And to have the other 50 that are going to have all these biopsies for those 10 years and never everything changed, not have those biopsies. So how can we do that better? And we're doing that here. And I can just show you that we've done a lot of work on what we call risk calculators. Dr. Gore's involved in this. Many people that have presented today to use these risk calculators to help us have decision making. There have been many developed in all sorts of other diseases. And active surveillance definitely presents an opportunity, again, to say if and when we should do a biopsy or who should proceed directly to treatment. And I'll show you a couple screenshots. This is our first one. It was version 1.0. It was many years ago. It needed a lot of work. But it did actually put in things like age, how many months, PSA, how many cores, and so it had a big list. And what it would turn out would be these smiley faces and maybe there's no green smiley faces. There was only yellow faces. But these are the ones that we're going to have a progression event. We've changed this now. We've included a lot of other things. We created, and I'll show you here, we have created many more modules, and now we have age, BMI, PSA, prostate volume, negative biopsies, and actually the screen goes down. I can't show you all the things. You put all that into a calculator, and then it will show you the chance of having an upgrading event, the chance of having something what we would consider bad happening, actually, on another biopsy. All right, and so we're now expanding the way that we can kind of operationalize all the information that we have, and we can actually get men off of active surveillance more quickly. Again, we've done some usability surveys, and then the group that I work with now didn't really like the smiley faces. They wanted, figures of men, which is fine, but this is for a patient-centered report to have give to the patient and to say, here are your chances of having a negative event happen to you over the next 5 years or next 2 years or something like that. And so we're doing this all now, and I'm going to end. I'm going to, again, skip this for sake of time. I'm running over. I thought I had 20 minutes. And just to conclude with just to give you an idea that, by the way, if you take a picture of this, I didn't know this. This is John Gore's work. You take a picture of this little symbol, and it will automatically link you to all the calculators online. Okay, so we have this all online for patients to use. There's no doubt that risk calculators can change depending on the individual over time. We think that we can actually use the risk calculator with the patient, with their caregivers, with their families to understand their risks of having, again, something like a progression event or reclassification later. And then, of course, our future directions will be working with patient groups, just like Dr. Gore and I have been doing, and many of you in this room have been working with us to understand a better way of calculating the risk of man just diagnosed with prostate cancer. So I thank you again for your time, and happy to take questions later. Okay.
Thank you. There we go. Thank you, Dr. Lin. So many of you have followed the exciting advances in immune-based therapy. You probably read about it in the news. These